Hello doctors, welcome back to the Gamechanger series by Dr. Sasi, and this is our radiology part. And about this radiology part, there will be mean that the usual number of questions in the radiology is 10 to 12. Okay, it seems much more when you see this radiology as a very small subjects, but it is hugely integrated with all the subjects like medicine, pedia. They have radiology part, and ortho it is one of the majorly dependent on radiology one, and then same medicine, surgery, OBG, everything it will be mixture of this radiology. That's why the question numbers will be 10 to 11, sometimes it can go up to 15, but the minimum number it will be 10. Okay, and there will be the general radiology part will be having 2 to 3 questions, or guess just 4 to 5 questions will be present from the general radiology part, whereas the rest it will be from the mostly integrated and systemic radiology only. Yeah, then we'll move on to this first part about this radiology, which is about this effects and the side effects of radiation. We see about the first effects of radiation. There are two effects. One is known as stochastic effect and another one is known as deterministic effect, which is also known as non-stochastic effect. So what is this effect signifies? For example, in few conditions will tell, right, because of this dosage of radiation this happened. Okay, whereas in few conditions will tell, right, this cancer happened because of this radiation exposure. We won't tell about the dosage. For example, in a case of carcinoma, we won't tell about the dosage. It is just this radiation exposure which is leading to the cancer. Whereas in a case of side effects, for example, skin erythema at this dose, and there is a bone marrow suppression at this dose, and GE suppression, like there is skin erythema, GE suppression, and along with this neural damage and bone marrow suppression, there is a sequential involvement. Okay, these are the two different effects what that you need to understand. So if you see about this stochastic effect, there will be a linear increase. So linear increase. So if it happened, it is just happened. If it is happened, it just happened. So it is known as stochastic effect, and it is not dose dependent. There is no D in the name, so it is not dose dependent. So if it is happened at this point, it is happened. For example, cancer of this thyroid, like especially we studied, right, papillary carcinoma thyroid. Papillary carcinoma thyroid, which has happened after neck radiation or breast radiation. Fine, radiation. Okay, and we know this radiation after the ALL. These all based on the stochastic effect. Yes, okay. Fine. And deterministic effect, it needs a threshold. Okay, and deterministic effect, it needs a threshold. For example, we start from physiology. There is an action potential, right? So there will be small sub threshold stimulus, and there will be a small this stimulus will reach a threshold, and once it reaches a threshold, it will spike up. Okay, the same thing here. Like there will be small doses, it will be nothing will be happening. Okay, whereas here there will be this, when there is exposed to this large doses, it will manifest as a symptoms. Okay, because of this over threshold. Okay, and the severity is different. For example, initially if low doses, it will be causing skin erythema as manifestations, whereas in high doses it may cause GI, then followed by this bone marrow suppression. Okay, so this is the two effects of radiation you should remember of. Okay, one is the stochastic, which is not dose dependent, which is leading to teratogenicity and cancers, whereas this deterministic leading for the side effects like skin erythema, skin erythema, and other GI manifestations, bone marrow manifestations. Fine. Then what are the side effects of radiation? If you see the side effects, the most common side effect, it is what is this? Skin erythema. And if you see the most common cancer after radiotherapy, it is the leukemia. And as I told you, the most common thyroid cancer following radiotherapy, it is this papillary carcinoma thyroid. And they will ask you, what is the most common bone tumor after radiotherapy? It is the osteosarcoma. It is the osteosarcoma. Fine. It is the osteosarcoma. Okay, and they will and just see from this table, like what are the changes can also be seen. For example, in the case of bone marrow, you can see there is a decreased blood counts. There will be aplasia will be there. There will be fibrosis will be there. In brain, it may lead to the usual scenario of nausea and vomiting. Okay, and in the case of esophagus, it may lead to this dysphagia because of stricture or radiation induced fibrosis and causing dysphagia. Fine. And in the case of bowel and bladder, it may lead to this small mucositis, which is leading to this what? Diarrhea and vomiting. Okay, diarrhea and vomiting. But the most common one, it is the skin first. Okay, and can anyone tell me which of the following is the radio sensitive phase of cell cycle, and which is the radio resistant? Okay, remember? Yeah, this is G2S or G2M. See, the radio sensitive, remember, sensitive won't have S. Okay, sensitive people, they won't show they are sensitive, like they won't tell they are sensitive, they actually cry. So remember, this radio sensitive one, they will be having, means it is due to this involvement or this radiosensitive phase of the cell cycle, it is G21, whereas S is the radio resistant. Okay, S, the single people, they will be resistant to everything. So S is the radio resistant phase. So radio sensitive is the G2M, radio resistant is this S phase. Okay, whereas this gonadal cells, they are radio sensitive. Gonadal cells are radio sensitive, whereas this neurons, they are radio resistant. And we know this in the case of in the case of blood cells, if they ask this WBC, which is having this nucleus, they are more radio sensitive, whereas RBCs and platelets, which lacks nucleus, they are more radio resistant. Okay, अब थोड़ा बहुत इतना याद रखना क्योंकि like they will ask you which of the following is the radio sensitive phase, which of the following is not a radio sensitive phase, like that they will ask. Yeah, Ewing sarcoma, it is one of the bone tumor which is radio sensitive in nature, whereas osteosarcoma, it happens because of radiation, so it is radio resistant in nature. Okay, it is radio resistant in nature. Okay, then about this size, this what is the usual lead apron thickness you will wear? So you will wear around 0.5 millimeter. Okay, 0.5 millimeter. Yeah, Mohammed Anush, it is the worms. Yeah, worms you will wear. Worms tumor, Ewing sarcoma and seminomas, you will be able to see these are all what? These are all this radio sensitive tumors. Fine. And next one, if you are able to see, this is the TLD batch, or also known as thermoluminescent dosimeter. Okay, here this they will ask you where you will keep this TLD batch, outside your lead apron or inside your lead apron. See, this TLD batch will assess this radiation exposure after this lead apron. So remember, you will keep inside the lead apron. So like imagine this as a lead apron. So we'll keep this TLD batch inside the lead apron. Remember, it is the inside the lead apron, and the size of the lead apron, it is what? It is this 0.5 millimeter. You will keep it inside the lead apron. Inside lead apron. Fine. And you see this this TLD batch, it is made up of lithium fluoride, and in India it is made up of calcium sulfate. It is in India it is made up of calcium sulfate. In India it is made up of calcium sulfate dysprosium. Fine. And see, this TLD batch, it is given for every 3 months. Every 3 months. It is given for every 3 months. Fine. And then you need to know a few more things. For example, this ionizing radiations and non-ionizing. Okay. Non-ionizing pehle yaad rakho, ultrasound and MRI, they are non-ionizing. Whereas our X-ray, CT, mammography and our this radionuclide imaging. Radionuclide imaging, okay, which uses this gamma rays, they are what? They are this ionizing radiations, whereas non-ionizing is ultrasound and MRI. So see, if a children is presenting to you, if a children or pregnant female is presenting to you, then your first identification modality should be used. It is either ultrasound modality or a MRI modality to prevent from this radiation exposure. Fine. Next, they will ask you if there is a female who is pregnant and she don't know that, without knowing that she is pregnant, she took a X-ray. So what do you will think? If she took a X-ray, what you need to do? Like you will tell to abort, or you can continue the pregnancy. What you will do? If X-ray also taken, don't worry, just reassure her and tell her to continue the pregnancy. Okay, we don't abort it. We'll do what? We'll do continue the pregnancy. Next, we'll move on to this next part, which is this foreign body. See, this foreign body is being repeatedly tested because there is more emergency as well, it is a radiology as well, and it is a EMT as well. Fine. If we see about this tracheoesophageal foreign body, see, write this word as esophagus. Okay, and esophagus, how we are seeing this esophagus? We are seeing in front of, means this iPad or the phone, it is in front of you. So this is, if it is in complete coin in AP view, so esophagus, if it is complete coin in AP view, it is what it is, this present, the foreign body is present in the esophagus. Fine. So if it is what it is, this complete coin view, whereas in the case of lateral view, you can see this is this slit formation if it is in esophagus. Fine, esophagus. See, if they will tell there is a coin in the esophagus, the patient is presenting with dysphagia. Okay, then you can what you can do, either if it is crosses this cricopharyngeal junctions, then you can wait and watch. Okay, if they tell if there is a coin in esophagus, a coin in trachea. So if there is coin in esophagus and if it is crossing this cricoesophageal junction, then you can wait and watch. Wait and watch. Okay, whereas in a trachea, you need to remove immediately. Remove immediately, because it will cause what? It will cause dyspnea, okay, or difficulty in breathing, and the patient even may die. Okay, this is a coin case. Whereas if you see this one, which is this double ring sign, like if you're able to see, this coin, which is showing this one more double ring sign, or there is two elevations. It is what? It is not coining. If it is a circular body which is having this type of arrangement, it is what? It is this disc battery. Disc battery. So remember, if disc battery is anywhere, yeah, it can lead to this alkali injury. If disc battery in esophagus, is disc battery in trachea, coina, okay, if anywhere it is there, you should do immediate removal. Because it will be made up of alkali, it can cause perforation of the esophagus, and if it is trachea, it can cause perforation and also respiratory distress. So this they will mention. This coin battery means the following foreign body is being shown, where you will see two densities, two level of densities, one ring outside, one ring on the inner side, and you will be able to see that is a battery. So if it is in esophagus, what you will do? The first option, and it is crossed with cricoference. If it is crossed, uncrossed, we don't matter. If it is disc battery, we'll remove it immediately. Okay, we'll remove it immediately, fine. And if it is any foreign body in the trachea, we'll remove it immediately. If it is coin or if it is disc battery. Fine. The opposite of this will be seen in a case of trachea. Opposite of this will be seen in a trachea. In trachea, AP view, you will see formation of slit. Means it's based on the level. Mostly we'll do rigid bronchoscopy, because if you do flexible, means it won't flux and take up. If it is in the other bronchial level, at very distal level, then we can use this flexible one, whereas it will be mostly in the upper part, because these are large structures. Then we'll use this rigid wala bronchoscopy and we'll remove it. Fine, we'll use this rigid bronchoscopy and remove it. Whereas if it is in esophagus, we'll do esophagoscopy or our usual endoscopy and we'll take it out. Fine, okay. So then tracheal antibody, the T पे भी दिख रहा है, ठीक है. अगर trachea esophagus में तुम्हें confusion, बस उसका नाम को just see its name. Esophagus, if it is in the anterior aspect, so if you see here, so it is what? It is the anteriorly we'll be able to see the full con view. Whereas if you see the trachea, it is T, like a tie. So in anterior posterior view, it will be having this slit shape. Okay? Don't try to memorize lot of things and forget the necessary things. Okay? तो इसीलिए हो सकता तो एक को याद रखना, नहीं तो दोनों याद रखोगे तो it will be good. If you are able to remember two things, it's best. If not, at least remember this esophagus and forget about this trachea foreign body. So in tracheal foreign body, on the AP view it will be slit in nature, whereas in the case of lateral view, it will be a full coin view. It is a full coin view. Right? It is a full coin view. Yeah. Next, about this few neurological imaging, if you see, you will able to see this type of sign, where you will able to see this tails of the dura. So this type of dural tail sign will be classically seen in a case of meningioma. So you will see this dural tail sign in a case of meningioma. Okay? और हमें पता है what is the name of the bodies you will see in a case of meningioma? This is a dystrophic body. It is what it is. The pneumoma bodies. It is the pneumoma bodies. Dystrophic calcification. Yeah. It is seen in a case of papillary carcinoma, thyroid, meningioma, serous adenoma, ovary. Okay, remember. You're able to see this type of mass. Okay, which is around this shape of 8. Okay, around this shape of 8. It is what it is. This pituitary adenoma. Okay, pituitary adenoma. Okay, there are two things. If you are able to see this type of cystic lesion, if this presence means fluid containing. If there is a presence of fluids, along with this there is a calcification. अगर दोनों है, cyst भी है, calcification भी है, then it is what? Then it is craniopharyngioma. लेकिन if it is just a 8-shaped mass, it is what it is. This, which is the pituitary adenoma. It is the pituitary adenoma. And can anyone tell me if the pituitary adenoma causes compression over this optic chiasma? अगर ये optic chiasma के ऊपर compress कर रहा है, it will produce which type of visual field defect? It will produce which type of visual field defect? Visual field defect. Yeah, it is the bitemporal hemianopia, also known as heteronymous hemianopia. It is also the heteronymous hemianopia. Okay, याद रखो. Then, if you are able to see this type of ice cream cone appearance, it is seen in a case of on gadolinium enhanced MRI, it is seen in a case of acoustic schwannoma. It is seen in a case of acoustic schwannoma. Okay, acoustic schwannoma. Next, if you are able to see this type of necrosis, okay, and if it is, sometimes it will involve this bilateral lobe, it is known as what? It is the glioma, especially this glioblastoma multiforme. It will produces this butterfly. Yeah, there will be presence of this serpentine necrosis. Okay, fine. फिर उसके बाद this hemorrhage. So SDH, EDH and subarachnoid hemorrhage. Okay, so you see the first thing is SDH will be what? It will be banana shaped. It will be banana. Okay, it will be banana. See, if you see this banana shaped, or this crescent shaped, it is seen in a case of subdural hemorrhage. And this subdural hemorrhage, it is due to the damage to this bridging veins. It is due to damage to the bridging veins. Okay, and it is most commonly seen in children, where it will shake the baby, right? Shaken baby syndrome. Okay, children you will see, and also it is seen in a case of elderly. Elderly also you will be able to see. Okay, this is the two things you will see. Fine. Next, it is this EDH. Okay, EDH is epidural and extradural hematomas. EDH, remember? This EDH, remember, it is which shape? Idli shape. Okay, idli shape. Are this limb? Okay, so remember, who will make the best idli? Okay, who will make the very soft, fluffy idli? Yeah, who will make the best and soft, fluffy idli? Our ma. Okay, so remember, the idli will be made by our mother, ma. So it is ma. So it is middle meningeal artery, which will be responsible for bleeding in a case of epidural hemorrhage. So it will be idli shaped, and ma will make this soft idli. But हम क्या करते हैं? हम प्यार के चक्कर में माँ को भूल जाते हैं. So there will be interval in your life where initially means you will be unconscious, there you will get conscious, and again you will become unconscious. Okay, so this is known as what? This is known as lucid interval. Lucid interval. This is known as lucid interval. Will be seen in the case of EDH. And this middle meningeal artery, it will bypass with this foramen, which is known as foramen of spinosum. Foramen of spinosum. Okay, it will be passing through this foramen, which is known as foramen of spinosum, and there will be classically tell there is a trauma occurring at this region. Yeah, somebody already told this trauma at this region, which is known as terion, Okay, which is known as terion. Fine. And next, you saw a patient who is presenting with features of hypotension with thunderclap headache. Okay, this is the classical feature of this subarachnoid hemorrhage. Where you will be able to see the sulcal spaces which are being filled with the blood. Okay, sulcal spaces which are being filled with the blood. Okay, Okay, so and in a case of any stroke, let me ask you a few questions. In a case of stroke, what is the first investigation you will do? Guys, is it NCCT or CECT? See, in a case of any emergency management, whatever you do, it should be simple and it should not be time consuming. So what we'll do, we do NCCT because it will be very quick. That's it, done. We'll just bring the patient out. So this NCT will be taken in minutes, and this NCCT will be able to differentiate or tell it is which type of stroke. There are two types of stroke. One is hemorrhagic stroke, next one is the ischemic stroke. In the case of hemorrhagic stroke, it will be showing this hemorrhages. Okay, it will be showing this hemorrhages. Whereas in the case of ischemic stroke, it may be normal. Or it may be suggestive of some hypodensities. Okay, so if there is a hemorrhage present, हम सोचेंगे yeah, it is a hemorrhagic stroke. Then we need to look into the causes. Like if it is hypertension, we'll check for the BP. Then we'll control, and along with this, we'll give what? We'll move for this, which vessel is bleeding, and we go on that one ligate it. So this is the hemorrhagic stroke. Whereas in the case of ischemic stroke, if there is ischemia, mostly it is due to the formation of clot formation will be there, and we need to go and break the clot. Okay, we need to go and break the clot. So we'll do NCCT. If it is hemorrhagic, what we'll do? We'll go for its further management, like with reduction in BP and also clipping of the vessel which is bleeding. And next, if it is what? If it is ischemic stroke, the NCCT will be almost normal. Okay, normal, sometimes there will be changes. So in such cases, we'll go for thrombolysis. But thrombolysis will, before that, we'll check for BP. Okay, for prevent of that's a management part, right? There will be cerebral edema, will decrease cerebral edema by providing mannitol. Okay, we'll give supportive care, supportive therapy. Okay, and we'll check for like whether the patient is hypertensive, whether the patient is a diabetic patient. If it is hypertensive, we'll measure blood pressure and we'll reduce him gradually. Like if it is more than 180, then or 160, then we'll start giving thrombolysis. So there is this management protocol. There will be this golden period where within 4.5 hours you should give this thrombolysis. Okay, fine, just remember. Next, if you are able to see this type of finger-like projections near the ventricle, which is especially seen on the tubule attenuation and inversion recovery sequence, it is suggestive of Dawson's finger, which is suggestive of this multiple sclerosis. And then, if you are able to see this sagittal sinus, especially the superior sagittal sinus inside, if you are able to see this type of empty delta sign, it will be suggestive of this cerebral venous thrombosis, especially the superior sagittal sinus thrombosis. Yeah. And next, if you are able to see here, this type of sign where air anywhere, for example, in the case of pneumo in the intestine, okay, or pneumoperitoneum, or in the case of pneumothorax, or even in the case of pneumothorax, in the case of air anywhere, will use CT. So if you see this type of CT image, where this is this brain, and there is a accumulation of air in the brain and causes this compression. So we know this air will always tend to go up. Okay, that's why if you see in the case of pneumoperitoneum, we'll tell the patient to stand so that the air will come up under the diaphragm and will take the image. Okay, likewise here also what will be there, this air when we tell the patient to lay, the air will come into the anterior aspect. Okay, that is the air present in the brain, which is known as pneumocapillus, and if it causing this ventricular constriction or compression of this ventricles, it is known as tension pneumocephalus. Okay, in last May I said they just given this image and they asked what is the diagnosis. The answer is tension pneumothorax. It is the tension pneumothorax. इसमें बिल्कुल गलती नहीं करना. See, the air is there, which is black in color, and see, this is the bone is white. It is the CT. Okay, then we'll move on. You're able to see this type of cross Bunsen or hot cross Bunsen. Where you will see this hot cross Bunsen. You will see in a case of multiple system atrophy. Especially in type C. And next, if you are able to see this type of tram track calcification, is specific for this Stooge-Weber syndrome. It is specific for this Stooge-Weber syndrome. And see, where you will see this tram track, that is Port-Weinstein. I will show you in dermatology. Okay, tram track appearance on renal biopsy. Okay, on renal biopsy, in which condition we will see this splitting of the basement membrane causing this tram track sign. Splitting of basement membrane causing this tram track sign. किसमें देखेंगे? You will see in a case of MPGN. There is membranous glomerulonephropathy, which is the most common cause of nephrotic syndrome in elderly and cancer patients. Whereas there is a P which is separating this MGN. Like membranous, we'll call them as MGN. Whereas there is a P is coming and it's separating. Okay, like a train track, it is separating. So it is known as tram track appearance or train track appearance. Okay. Whereas in a case of HRCT, where you will see this tram track appearance on HRCT, we'll see this tram track appearance on HRCT in the case of bronchiectasis. We'll see two things. One is this signet ring shape and another one is the tram track appearance. Okay, if I cut this bronchus like this, it will look like a signet ring. Whereas if it will be going like this, like if I cut like this, it will be what? It will be tram track appearance. Yeah. Right. Next about this pneumoperitoneum. I told you this pneumoperitoneum. This pneumoperitoneum will be having air inside this. Mostly it is due to the perforation or trauma, especially more commonly it is due to the perforation part, especially in a case of duodenal perforation, or in a case of tuberculosis, or in a case of typhoid, there will be a perforation. Okay, there will be ulcer formation and perforation. For example, in a case of Crohn's disease, there will be perforation. So all of these things, it will manifest as pneumoperitoneum. So in a case of pneumoperitoneum, as I told you, air will come and it will go and sit. The air will come and will sit under the diaphragm. So it is known as air under diaphragm cell. Okay, here you will be able to see there is this air which is sitting under the diaphragm. So okay, so it is the air under diaphragm. It's fine. And as I told you, air anywhere. The diagnosis is kya? Diagnosis is CT. Okay, air sometimes can be present in around the central tendon of the diaphragm. Okay, central tendon of the diaphragm, if the air present, which is known as cupola sign, which is known as cupola sign. Okay, if the air is present at the central tendon of diaphragm, which is known as cupola sign, which is known as cupola sign. Fine, and as I told you, there you will be able to see this air in the diaphragm, and mostly we'll tell the patient to stand erect, because I told you air will come upstairs, air will come upstairs. Okay, so that's why we'll take chest X-ray erect. Fine, and there might be this air which is present in this hepatorenal pouch, it is known as Doggy's capsule, and there if the air is present, bubble inside the bubble there will be a food and air. So if bubble inside the food also there is air, and outside also there is air, it is known as what? It is known as Wriggler sign. It is known as Wriggler sign. It is known as Wriggler sign. Yeah. If there is any presence of extraluminal air, it is known as telltale triangle sign. It is not much important. And there are two more signs, like where you are able to see this along this umbilical ligament, it is known as inverted V sign, and if it is along the medial umbilical ligament, it is the Urachus sign. Okay, and the falciform ligament can be visible as well. Okay, if there is air occurring around these ligaments, then these ligaments will be promptly visible. Especially here you need to know about this inverted V sign. Okay, whereas in the case of duodenal perforation, we know we'll keep this, or we'll bring this omentum along with this blood supply and we'll patch it. So it is known as what? It is known as omental patch. Okay, omental patch. Remember, yeah. Also known as Graham's repair. Yeah, it is the omental patch or this Graham's repair. Then next about this prenatal USG finding. Okay, first, what is the first investigations? Whatever you will do, it is the CVS, chorionic villus sampling, followed by this amniocentesis. Okay, around 30 weeks. Okay, here around 16 weeks, and amniocentesis, then cordocentesis around more than 18 weeks. Okay, this is the sequence. Like first you will do chorionic villi sampling, then you will do amniocentesis, then you will do what? You will do cordocentesis. So CVAC, cordocentesis. First you will be chorionic villi sampling, amniocentesis, and chorionic, then cordocentesis. Fine, just remember. We'll do this antenatal USG from this week of 11 to 13 weeks, or 11 to 13 weeks plus 6 days. Usually it is what is the 11 to 14 weeks. Remember. And what is the most, or what is the most accurate thing which will tell that is the gestational age? It is what it is, the CRL, which is this crown rump length. It will tell this exactly. It will tell exactly like what is the gestational age. So the most accurate one, it is the CRL. Okay, and it is done in this mid-sacral section with neutral flexion. It is not overflex, it is the neutral flexion. Okay, and the nasal tip and palate should be visible. And here you will be able to see there is a presence of nasal bone, and along with this there is this nuchal thickness. There will be thickness around the nuchal thickness, and if there is any hyperdiploidy, like for example in the case of Down syndrome, then there will be a presence of this increased nuchal thickness, and this nasal bone will be absent. Okay, this normal nuchal thickness, it will be less than 3, and if it is more than increased nasal thickness, then there will be, it is a soft marker for this aneuploidy. Then we'll go for this dual marker, triple marker, and quadruple marker testing. Fine. And next they will ask in the last examination, where you will see this banana and lemon. See, if there is any spina bifida, or if there is a neural posterior field defects, then this leads to this herniation. So the around the cerebellar vermis, it will become empty. So this is known as what? This is known as banana sign. And at the same time, this skull will become small. So it is like a lemon. It is known as what? Yeah, SDH also banana. That is another banana. But here they are asking where you will see this banana and lemon sign in antenatal USG. You will say in the case of antenatal USG, you will see in a case of where? In the case of spina bifida. Okay, banana sign. Okay, it is this abnormal anterior curvature of this cerebellum. Okay, because and it produces this banana sign. Okay, whereas this lemon sign also seen here. Okay, and usually it will be associated with this Arnold-Chiari malformation. It will be associated with this Arnold-Chiari malformation. Just itna yad. Okay, where you will see this banana and lemon sign, you should tell it will be seen in the case of spina bifida. Okay, next, if the fetus is death inside, then it may lead to this few changes. For example, the brain will undergo this lysis, then the skull bone will start to overlap. Like usually the skull bone will be like this. Okay, the parietal bone, temporal bone, they'll be having a suture, so they'll be having the gap. So after death, what will happen? Skull bone, it will start overlapping. So this overlapping of the skull bone, it is known as cranial bone. It is known as Spalding sign. It is known as Spalding sign. Whereas it will come after 7 days of death. Okay, whereas the first one, it is known as Robert sign. Robert sign is nothing but the large vessels like aorta, vena cava, it will be started to have air. In the case of circulations, we won't be having the air. So if there is presence of air inside this large vessels, it is known as Robert sign. It is known as Robert sign. Okay, gas present in this heart and great vessels. It can be seen as early as 12 hours. And this is your favorite frog which came here. If you are able to see this type of frog eye sign, it will be suggestive of anencephaly. And we know anencephaly is one of the changes which we can diagnose very much early, because we know this cranial, this anterior neuropore, it's not closed. Usually it closes at 25th day. If it is not closed, it leads to this opening and causes this anencephaly. Okay, yeah. And this is this also view which is showing that there is a defect in this. There is a defect. You can see there is a defect here. So it is what it is, this anencephaly. Next, you just read these things, and I'll give this table. If you could able to remember, just read rest of them also, or else you should at least read them. Okay, fine. Just gallium 60 signs will use for this sarcoidosis. Okay, we studied right in sarcoidosis. We'll see asteroid bodies and Schumann bodies in pathology. Then in a case of lungs, you will able to see in X-ray. If you take, you will able to see this type of sign which is known as lambda sign. Okay, lambda sign means there will be this around this trachea. There will be both sides, there will be this around paratracheal lymph node involvement, okay, and both hilar will be involved, and along with this paratracheal involvement. This will produce this sign which is known as what? This is known as what? Lambda sign. This is known as what? This is known as lambda sign. This is known as lambda sign. And in a case of scintigraphy with gallium 16 scan, it will produce this pituitary gland enhancement, okay, which produces this face of panda sign, Next, this technetium 99M HMPAO spect. It is used for the cerebral perfusion. For example, in a case of after stroke, you need to know whether the cerebral perfusion to the specific areas maintained or not. There you will do HMPAO. And next, iodine 123 along with this ephosplurans spect. It is used in a case of dopamine transporter scan, like DAT scan. For example, in a case of pheochromocytoma, we need to measure, right, where is this pheochromocytoma is located. There we will use this DAT scan. Next is 18 FDG PET, which is used for this metastasis, usual metastasis. And they will ask you what is the T half. It is this 120 minutes. It has a T half of 120 minutes. Yeah, it is especially for the stage, means especially for the metastasis, where there is presence of metastasis or not. Okay, remember. T11 methionine PET is used for this brain tumors, for their activity, and N13 ammonia. It is most sensitive for this myocardial perfusion. Means after MI, you should know whether this area which is undergoing the infarction is getting perfusion after thrombolysis or not. So there you will do this N13 ammonia PET. So remember HMPAO PET, which is used for the cerebral perfusion, whereas N13 ammonia PET, it will be used for this myocardial perfusion. Okay, and next the sodium fluoride. Okay, this sodium fluoride PET, it is used for what? The sodium fluoride PET, it is used for this skeletal metastasis. Fine. And DAPA PET, it is also used for this extra abdominal pheochromocytoma. Yeah. Sodium fluoride vacuum drainer, it is green color. It is used for collection of glucose collection. Fine. And technetium 99 MDP, it is used for this detecting the osteolytic, or how to differentiate between the osteolytic or osteoblastic metastasis. Fine. So remember these things. Then yeah, we'll just quickly go through this. If it is Hidascan, like if there is any biliary atresia, we studied there is a conjugated hyperbilirubinemia. So we need to know whether this bile is transferring or not. Then we'll use this, do the scan, which is known as Hidascan. Okay, it is used in a case of biliary atresia, and also it is used in a case of cholecystitis. Because why it is in cholecystitis, there will be inflammation. In a case of inflammation, the glands will be swelled, and this also won't come down. So this is this cholecystitis. Okay, and with this, for this bilic also we can use this. Okay, biliary atresia, cholecystitis and bilic we can use it. And technetium 99M pertechneate scan. This pertechneate scan, it is used for this thyroid and salivary gland scintigraphy, and also for the Meckel's diverticulum. We know this Meckel's diverticulum, it will be having this ectopic foci from the stomach, thyroid and pancreas. So to detect this, we'll use this technetium 99M pertechneate scan. Yeah. Next, DMSA, as I told you, it is for the structure of the kidney. SA, it is the structure of kidney, all anatomical and scars. And DPA, TTPA, it is the physiology. Kidney का function क्या है? filtrate karna. So it will produce this GFR. So it is used to evaluate the GFR. Fine. And MAG3 it is used for this renal perfusion. Renal को कितना perfusion मिल रहा है और perfusions के साथ वो कितना काम कर रहा है, that is MAG3. So most superior when compared to DTPA to the MAG3, MAG3 is more superior than DTPA. Fine. And technetium 99 system maybe it is as in previous FMGE, that is the parathyroid adenoma. And in the case of parathyroid malignancies, we'll use this technetium 99M cysta may be used for this parathyroid gland. Okay, MIBG it is used for pheochromocytoma. And as I told you, there are different studies which are used for this myocardial perfusion, and the most specific one kya? It is this N13 ammonia PET. It is the N13 ammonia PET. Whereas thallium also will use for myocardial perfusion. Okay, whereas pyro it is hot, so it is used to detect this hot, matlab taja, like we will call it hot, garma garam myocardial infarction, means like very hot lesions like myocardial infarctions. We need to pick it right away. We'll use this technetium 99 pyro, means fire. So pyrophosphate scan. Remember. Next, RBC scan also for GI bleed. For example, in a case of Colles disease or in a case of any GI malignancies, there will be very minimal bleeding that you cannot see with endoscopy. And once you do this full occult test, this bleeding will be happening, but you don't know where it is happening. So in such cases, you will give this radio-labeled RBC to the blood, and you will see where this RBC are coming in. Fine. Remember. And MDP we told it is used in bone scan, and iron 11 it is used for this occult abscess. For example, in the case of any mastoid abscess or in case of any temporal abscess which is complicated, there we will use. And technetium 99M macro aggregate of albumin which is used for this ventilation and perfusion scan. Okay, ventilation perfusion scan for this pulmonary thromboembolism. And sulfur chloride scan, it is used to differentiate between these two things. For example, in liver there will be two conditions will be having this central stellate scan. Yeah, central stellate scan. Okay, stellate scan. So you need to differentiate between you and your friend, like who looks exactly similar. So because both of them you are wearing the white coat, then you will ask the name and you will ask your properties. So likewise, if you see this focal nodular hyperplasia, it is just this inflammation which is causing this hyperplasia. So in such cases, it will take up more sulfur colloid because of this high macrophageal activity. So it is known as technetium 99M sulfur colloid. It is known as technetium 99M sulfur colloid scan. Fine. And gallium 69 we told it is used in a case of sarcoidosis, and HMPO PET for cerebral perfusion, and ifluinospect also we told it is for this dopamine, and 18-FTG for this cancer staging. Methionine, ammonin we told, sodium fluoride also we told, dopa PET also we told for extra-abdominal pheochromocytoma. Okay, and actinium which is used for neuroendocrine tumors. Yesterday we studied, right? The insulinoma, gastrinoma and VIPoma. Okay, gastrinoma which is the Zollinger-Ellison syndrome, which will occur in a triangle which is known as Pazaros's triangle, and this is most common site of this gastrinoma. क्या it is the duodenum. Okay, and treatment के लिए हम क्या करेंगे? Proton pump inhibitor देंगे. Then it can be used in a case of VIPoma. VIPoma there will be a diarrhea along with this hypokalemia, which is an electrolyte abnormalities, and other electrolyte abnormalities as well. Fine. And DOTA-PET, this is also for neuroendocrine tumors, and DOTA-TET-SPECT for this neuroendocrine tumor, which is both diagnostic and therapeutic as well. Fine. Yeah. In the case octreotide, if you give just octreotide drug, it is used in the case of esophageal varices. Okay. Then PSMA PET it is used for prostate specific, so it is used for this prostate cancer, and for Alzheimer's we'll use this Pittsburgh component which is known as PET. Okay. Then the WBC scan, as I told you, it is used for occult abscess, and extended PET it is used for insulinoma. Okay, remember just a few things, like just go through this, you will just get an idea. Okay. Then about this types of radiotherapy, like we are about to finish radio with the types of radiotherapy. If you see about this types of radiotherapy, there are different types. For example, we studied about this radiotherapy for esophageal cancers, like especially for this ovarian cancer, like we studied for the cervical cancers. Okay, so in such cancers we use this radiotherapy. So this radiotherapy include regular fractionated. It is regularly we are giving and fractionately we are giving. How we are giving? You see, you are giving this 1 to 2 gray, which is regularly, which is fractionated, like fraction which only 1.82 gray will give. And how will you give? You will give for regularly for 5 days per week for a duration of 6 to 8 weeks. So it is known as regular fractionated radiotherapy. Whereas in the case of fractionated radiotherapy, what you will do? You will give 5 fractions per week. OD for Monday to Friday. Okay, it is the 5-1. Okay, remember. Whereas here, you know this dose which is being fixed, and you will give for 5 days per week around the same, and it is 6 to 8 days will give. Okay, it is around the same of regular, and it is the regular fractionated radiotherapy. And about hyperfractionated will give more fractions. Okay, instead of OD which we are giving here, we give BD, means 2 times a day. 2 times a day will give. Okay, and it is being given for this aggressive cerebral gliomas and small cell lung cancers. Fine. And hypoproportionated means will give less radiation. For example, in a case of bone metastasis, single, only one bone metastasis. So in such cases, we'll give hypo, like less 5 fractions. Like see here, in a case of a regular, it is 1.8 to 2 gray of radiation, and it is given 5 days per week, once a day. Whereas hyper, it is 5 days or 5 fractions per week, and it is what? And it is given like it is given twice. It is the hyperfractionated. Whereas hypo, we are already giving only once. In the case of regular, we are giving only once for 5 days. So we will reduce the days. So it is the less than 5 fractions per week. Okay, and it is used for palliative, means just to decrease their pain, especially in a case of single bone metastasis. Fine. And accelerated means rokanai jara, means you cannot even stop. So it is in such cases you will use this accelerated fractionated radiotherapy. For example, in a case here you will use more than 5 fractions. So here the number is 5. 5A to regular. If it is 5 OD, it is regular. If it is 5 BD, it is hyperfractionated. If less than 5, hyperfractionated. If it is more than 5, it is accelerated. Okay, accelerated. Okay, so we use this continuous hyperfractionated accelerated regimen for this non-small cell lung cancer, like for example squamous cell carcinoma and adenocarcinoma. Okay, just see, because they tested two times from this radiotherapy part. So make sure you are reading it. Fine. And next, what are the other methods we'll use? This is known as remote after loading. Means you just first, as a surgeon, as a chemo oncologist, what you did, you just put up the empty pellets, and you went outside the room and you made the robot to insert this thing. So this is known as what? This is known as remote after loading, which is seen in a case of brachytherapy. See, this is this radiotherapy one, and this is this empty pellets which you already inserted. Okay, fine. Yeah. In a case of CS cervix, we'll use this tandems. Okay, we measured, right? Two points, point A, point B, 2 centimeter lateral from this lateral and superior to this external os, and if it is 5 centimeter, it is the point B. Remember, fine. And next, if you give from this outside, it is what is a teletherapy. And for teletherapy, we'll use a instrument which is known as linear accelerator. Means linear accelerator, which uses this X-ray, because gamma rays, they are natural rays. So means, for example, if something is natural, if river is flowing, it will flow in its own way. Okay, but if you are building some canals, you can build by your own way, and you know you can direct them. Likewise, if you see gamma rays, it is naturally, you cannot reduce, increase, it will produce, it will go off. That's it. Whereas in the case of X-rays, it is man-made, it can be produced. So how will you produce? You will produce based on your need. Okay, that's why we'll use the instrument which is known as linear accelerated, and it will be used for this teletherapy unit. Okay, and we'll use one more therapy which is known as stereotactic radiotherapy. Stereotactic radiotherapy means we'll keep up this radiotherapy probes which is made up of cobalt, and we'll keep in a way so that all of them will focus on this, all of them will focus on the exact tumor material. So it is known as stereotactic radiotherapy. For iske liye hum will use this frame which is known as, what is the name of this frame you will use? Yeah, what is the name of this frame you will use for this stereotactic radiotherapy? It is known as Lescal's frame. It is known as Lescal's frame. Remember, it is known as Lescal's frame. Okay. So this is the stereotactic radiotherapy. Mostly we'll use in the case of small tumors, or in the case of any, like this one, temporal neuralgia. Yeah, it is known as Lescal's frame. In the case of temporal neuralgia. Yeah. Okay, in such cases we'll use. We know we can use drugs also, but for any vessels, this one we'll use this stereotactic radiotherapy. Fine. And the final one, it is the BIRADS and thyroids. The BIRADS, it is for breast reading, and thyroids, it is for thyroid radiation. Okay. 0 in a case of means, for example, when there is any breast cancer, what you need to do? You need to do yearly. So if you see about this breast cancer evaluation, you need to know triple assessment. You need to do history taking, you need to do clinical examination and radiological examination. And this radiological examination may differ based on this radiologist. So we brought up a uniform. For example, if you are a radiologist sitting in Delhi, if you are a radiologist sitting in Chennai, if you are a radiologist sitting in Hyderabad with me, then these three people should write the same. Okay, if a female come to me in Hyderabad, or if a female who come to me when I'm in college in Delhi, then if I go to home in Chennai, then I should report the same. I should see the reports and it should be similar and it should be uniform. So it is what? It is the BIRATS. It is the BIRATS. Okay, it is the BIRATS one. Okay, remember. So for this we use this uniform method. So if it is category 0, then it is what? Then it is need an additional environment. You need more information to tell it is which state it is. But if it is 1, it is negative. If it is BIRATS 1, it is negative. So we will go for routine screening. Whereas in the case of 2, it is benign. For example, you see this popcorn appearance on mammography. Where you will see? You will see in the case of fibroadenoma, it is a benign lesion. So in the case of benign lesion also kuch nahi. Until unless it will be very much causing pain or any huge cosmetic defect, you won't do anything. Okay, so fibroadenoma, it is a benign. About 3, it is the probably benign. Like you think it is a benign condition, but it may turn into malignant. So in such cases, you will tell them for a short-term follow-up for 6 months. Whereas 4, it is suspicious. When you have a suspicious like paranoid disorder, then you should clear it off, right? So you need to do biopsy and check whether this is malignant or not. So you need to make true cut or core cut biopsy, which is the tissue diagnosis. Fine. And next, finally, you made means you have high suspicion. Yeah, this is malignancy. Then you obviously go for the tissue diagnosis. Whereas BIRATS 6, it is already biopsy proven malignancy. They come to rule out for any post radiation therapy or post surgical residual disease. Okay, post surgical residual disease. So 0, it is incomplete. 0, it is incomplete. Whereas 1, it is negative. Whereas 2, it is benign. 3, it is probably benign. So you need a short-term follow-up for 6 months. And 4, it is suspicious. So you need to do tissue biopsy. 5, it is probably malignant. You need to do tissue biopsy. 6, it is already biopsy proven malignancy. Okay, you should remembering all these points about this BIRATS scoring. They will ask. Then about this thyroids, which is also around the same. 1, it is a benign. And 2, it is not suspicious, it is mildly benign. Fine. 3, it is mildly suspicious. Okay, if it is 1C, means then it is a cystic lesion. It is a cystic lesion. So as this is cystic lesion, you can aspirate the fluid. Okay, and if it again comes, then you need to aspirate again. So you need to re-aspirate, and you can do these things for 3 times. Okay, remember. And 4, it is moderately suspicious. So you need to have a yearly follow-up. Okay, based on the size of the lump. And thyroid 5, it is the highly suspicious of malignancy. So you need to do tissue diagnosis or fine needle aspiration. If there is follicular origin, then you should do biopsy for sure. Or if it is papillary carcinoma thyroid, you can go directly for this thyroidectomy. So इतना आपको याद रहना चाहिए. बिल्कुल. Fine. Then about this is how this PET scan looks like. And PET scan, it is a functional scan. It tells you based on this effect of uptake of glucose. Okay, which is known as Warburg effect. Okay, because these tumor cells, they will take up much glucose than usual one. So this PET scan will use this FDG glucose, fluorodeoxyglucose, which having the T half of 120 minutes. Okay, so we'll check whether how it is uptaking. So if it is tumor cells which is having metastasis, it will be having this red color. So see, there is a metastasis everywhere. Okay, bladder either. Okay, so remember, so it is the PET scan, and we need to know this functional scan. We need to know exactly where is the metastasis. So then we can do this MRI, or we can combine this MRI along with the CT scan, and we can tell, yeah, anatomically either means here only will be the lesion or here only will be the metastasis. So we can diagnose. So it is PET CT or PET MRI. Now we are doing. Fine. And recently they started asking about this few normal or few X-ray techniques. See, you are holding the penile urethra. Okay, mostly it is done in males. This RGO. Okay, RGO, because female urethra, it is very short. Okay, so what is the pathology will rule out there. So whereas in a case of male urethra, it will be longer. So in a case of any trauma, okay, in a case of trauma or in a case of any post stricture or post stricture formation, you need to know where is the stricture. So in such cases, what you will do, you will do this evaluation. You will hold this penis and you will push the dye. Okay, you will push the dye and you will take up the film. So this is known as what? Retrogradely we are going. So this is known as RGU. Okay, retrograde urethrogram. It is used for analyzing the anterior urethral pathologies like anteriourethral stricture or any anteriourethral trauma. Right? Whereas if you see, you saw a child, with recurrent UTI, okay, you plan to do this investigation. You put up the catheter and you fill this catheter with dye. You fill this catheter with dye, and now you tell the child to urinate. Okay, you tell means you clamp the catheter, and now you tell the child, means see, this is the bladder. You put up the catheter. Okay, you put up the catheter. Now you fill this bladder with dye. Okay, once you fill this bladder with dye, then once you fill this bladder with dye, that is means radiopaque material, then you will be having this urinary catheter, right? This urinary catheter, you'll be having this bulb. Okay, so you clamped it. Once you clamp, and you will tell the patient to urinate. Okay, urinate means it is known as micturating. The patient is micturating, so it is known as micturating cystourethrogram. It is known as MCU, which is known as micturating cystourethrogram. And we will tell about the cystic, means urinary bladder pathology as well, and urethra pathology as well. Fine. Okay, ureter pathology as well. See here, if there is any reflex into this ureter, if there is reflex into this ureter, it is what it is this? It is this vesico-ureteric reflex. It is this vesico-ureteric reflex. It is the vesico-ureteric reflex. Fine. It is the vesico-ureteric reflex where you will use this MCU. Fine. And next, you have a patient who is presenting with this delayed passage of this meconium, and when you see this anal opening, there is no anal dimple. Okay, when you see the anal opening is empty. So in such cases, what you will do? What should be the location? You will keep a coin, okay, coin like this, and you will invert the baby to see how much the gas, or till how much rectum the gas is there, and you will take up this instrument in investigation, which is known as what? Which is known as invertogram. It is the invertogram used for inpopulate anus. Okay, we will keep a coin at anal dimple, which usually should be there. Okay, fine. So this is all about this radiology part that you should know. Okay, if you know this thing, mostly we'll get from this radiology general one on this about this radionuclide imaging part. Fine, and about the radiotherapy part. The rest mostly we covered during your medicine surgery as well, and respective subjects. You will be able to get through this. Fine.